A standardized Botox injection paradigm was developed for chronic migraine based on an in-depth analysis of the Phase 2 clinical trials. This paradigm consists of a minimum of 155 units of Botox administered as 31 fixed-site, fixed-dose injections across 7 specific head and neck muscle areas: corrugator, procerus, frontalis, temporalis, occipitalis, cervical paraspinals, and trapezius. Additional injections may be administered at your discretion, using a follow-the-pain protocol in up to 3 specific head or neck muscle areas: the occipitalis, temporalis, and/or trapezius, for a maximum total of 39 injection sites and 195 units of Botox. This paradigm, used in the PREEMPT studies, has been optimized to reduce the chance of adverse events based on the efficacy, safety, and tolerability profiles of the Phase 2 clinical trials. This injection paradigm provides optimal distribution of Botox to the muscles that align with the peripheral sensory afferents of the trigeminal and upper cervical nerves. These muscles, along with bony structures and other features that are easy to palpate or visualize, serve as anatomical landmarks to help identify these specific injection sites. Prior to treatment, one 200-unit vial of Botox should be reconstituted with 4 milliliters of preservative-free saline to produce the recommended 5 units of Botox per 0.1 milliliter of saline. A 30-gauge 0.5-inch needle should be used for the injections. If your needle begins to dull at any time during the injection procedure, replace it with a new 30-gauge 0.5-inch needle. Review the injection paradigm with patients prior to each treatment and inform them that injections will be given in the head muscles first, followed by the neck muscles. Describe how the injections are expected to feel, for example, like small pinpricks. Allow patients an opportunity to ask questions about the procedure before you begin administering the injections, and instruct them to let you know if they become uncomfortable during the procedure. Patients should be told not to rub or massage the area for 24 hours after injection, and that any bumps that appear on the forehead should disappear within approximately 2 hours. When you're ready to begin, ask the patient to lie down and make sure he or she is comfortable in a supine position. Let the patient know that after the injections in the head muscles are administered, he or she will be asked to sit up to receive injections in the neck muscles. The muscle should be injected in the following order. Begin with the corrugator, followed by the procerus, frontalis, temporalis, occipitalis, cervical paraspinals, and finally the trapezius muscles. Each injection site will receive 0.1 milliliters or 5 units of Botox. Inject the left side first, followed by the right for each muscle group. This will help you keep track of the injections if you are interrupted during the procedure. Commonly used tips for injection include holding the hub of the needle or the lower end of the syringe with one hand to ensure that the needle does not twist in the skin, placing the bevel of the needle facing upward in line with the gradations on the syringe will allow you to see which direction the bevel is facing while looking at the syringe gradations. Each site to be injected will require visual measurements, and knowing the width of your fingertip in centimeters can aid in determining these measurements during the procedure. One finger's breadth is equal to approximately 1.5 centimeters. The needle should be inserted through the epidermis-dermis layer, which may feel more rigid when penetrated. The injection should be given when there is a decrease in resistance. Avoid giving the injection in the dermis as there is less space for the injected fluid, and injections given here will cause the skin to blanch and may increase patient discomfort. In addition, it is important to follow your local or institutional guidelines and requirements for intramuscular injections. Each muscle group has additional best practice techniques, which we'll now review. Corrugator, procerus, and frontalis. Let's begin with the corrugator, procerus, and frontalis injection sites. The corrugator is located immediately superior and deep to the supraorbital ridge. To locate this injection site, go 1.5 centimeters or approximately 1 finger's breadth above the medial superior edge of the orbital ridge. Pinch the skin at this location. Hold the needle with the bevel up at an angle of approximately 45 degrees and superior to the eyebrow to minimize the risk of ptosis of the lid. In addition, the needle should be kept superficial to avoid hitting the periosteum, which may be very painful for the patient and may result in a periosteal hematoma or headache. Stabilize the hub of the needle with one hand to make sure it does not twist in the skin, and inject 0.1 milliliters or 5 units of Botox with the other hand. Repeat this procedure symmetrically on the contralateral side. The procerus muscle is located midline on the forehead, approximately 1.5 centimeters superior to the supraorbital ridge between the eyes. The injection site for the procerus should be approximately midway between the two corrugator injections. It may be helpful to visualize a single straight horizontal line connecting all 3 of these injections. Stabilize the hub of the needle and make the injection. Make sure the bevel of the needle is pointed up. Orient the needle upward toward the forehead rather than downward toward the eye to prevent ptosis. In addition, the needle should be kept superficial to avoid hitting the periosteum. The frontalis, a thin, broad muscle, will receive 2 injections on the right and left sides, for a total of 4 injections. Begin by visualizing a line up from the medial aspect of the supraorbital ridge. The medial injection site should be at least 1.5 centimeters or at least 1 finger's breadth above the corrugator injection site in the same vertical line. Ensure that the bevel of the needle is pointed up and that the needle is oriented upward toward the forehead. Make sure the needle stays superficial to avoid the periosteum. The next injection is just lateral to the medial injection. Visualize a line from the middle of the supraorbital ridge along the same horizontal line as the first frontalis injection. This will be at least 1.5 centimeters, or approximately 1 finger's breadth, away from the first medial injection, and may line up vertically with the mid-pupillary line. Point the needle at a 45-degree angle and stay superficial. Stabilize the hub of the needle and inject. Repeat this procedure symmetrically on the contralateral side. Temporalis. Let's review the next set of injections located in the temporalis. The temporalis is a large muscle that arises from the temporal fossa and the deep surface of the temporal fascia. The fixed dose protocol stipulates that 4 injections be administered to each of the right and left temporalis muscles for a total of 8 injections. The follow-the-pain optional dosing paradigm allows for additional injections based on the usual distribution of a patient's headache or areas of tenderness and pain in between headache attacks. In the temporalis, a maximum of 2 additional injections may be given unilaterally, 2 injections on one side, or distributed bilaterally, 1 injection on each side, in the temporalis for a total of 10 injections. For example, a patient could have 6 injections on one side and 4 injections on the other, or 5 injections on each side. Prior to injecting the left and right temporalis muscles, first palpate to determine the areas of tenderness and/or pain, and have the patient specify whether the discomfort upon palpation is mild, moderate, or severe. This will help determine the location for the additional injections using the follow-the-pain paradigm. The patient may also indicate that attacks are confined to or predominantly involve one temporalis, and therefore, even in the absence of pain or tenderness, you may decide to add 1 to 2 follow-the-pain injections into the temporalis. Begin by making the fixed dose injections. To locate the first injection site, find the tragus of the ear and move your finger vertically up the side of the head approximately 3 centimeters or 2 fingers breadth. Keep the needle superficial and pointed at a 45-degree angle to avoid the periosteum. Stabilize the hub of the needle and inject Botox at the first site. This lines up with a vertical line through the tragus. Move approximately 1.5 to 3 centimeters or 1 to 2 fingers breadth up from the first injection still in a vertical line with the tragus of the ear. Once your finger is approximately in line with the frontalis injections, stop and make the second injection. For the third injection, move forward toward the face, approximately 1.5 to 3 centimeters or 1 to 2 fingers breadth from the first and second injections. Make the third injection halfway between injections 1 and 2 and in line with the corrugator injections. This injection should still be within the hairline. For the fourth injection, move approximately 1.5 to 3 centimeters or 1 to 2 fingers breadth back from and in line with the second injection and in line with the mid portion of the ear. Make the injection. Repeat the 4 injections on the contralateral side. As previously stated, a maximum of 2 additional injections may be given unilaterally, 2 injections on one side, or distributed bilaterally, 1 injection in each side in the temporalis, according to the follow the pain paradigm. Occipitalis, cervical paraspinals, and trapezius. We will now review the occipitalis, cervical paraspinal, and trapezius injection sites. The occipitalis muscle is located on the back of the head, above the nuchal ridge. The fixed-dose protocol for the occipitalis muscle stipulates that 3 injections be administered to the right and left occipitalis, for a total of 6 injections. The follow-the-pain optional dosing paradigm allows for a maximum of 2 additional injections given unilaterally, 2 injections in one side, or distributed bilaterally, 1 injection in each side, in the occipitalis muscles. To locate the first occipitalis injection site, palpate the occipital protuberance and find the inion, or most prominent midline point, of the occipital protuberance. Palpate the nuchal ridge and locate the mastoid process behind the ear. Then, place your thumb on the midpoint of the occipital protuberance and your index finger on the mastoid process. Divide the space between your thumb and index finger in half. The first injection site is just above the nuchal ridge at this midpoint. Remember to avoid any bony structure. Before injecting, make sure the bevel of the needle is facing up and that the needle is on a 45-degree angle, to avoid injecting any additional Botox into the neck region. Then inject Botox superficially. For the second injection, measure diagonally 1 to 2 fingers breadth up and out toward the tip of the ear at the 10 o'clock position. Stabilize the hub of the needle, again with the bevel of the needle facing up, and make the injection. To locate the third injection site, measure diagonally 1 to 2 fingers breadth up and medial from the first injection at the 2 o'clock position. Make the injection. Repeat the 3 injections symmetrically on the contralateral side. In the areas of maximal tenderness and/or pain, up to 2 additional injections may be given unilaterally or distributed bilaterally. For example, 1 injection on each side, according to the follow the pain paradigm. To locate the cervical paraspinal muscle group injection sites, palpate the cervical spine. The fixed-dose protocol for the cervical paraspinal muscles stipulates that 2 injections be administered to the right and 2 injections to the left side, for a total of 4 injections. To locate the first injection site, measure approximately 1 centimeter left of the midline of the cervical spine and approximately 3 centimeters inferior to the inion, or most prominent point of the occipital protuberance. With the bevel of the needle facing up, stabilize the hub of the needle and make the injection. Make sure not to go too deep with the needle to avoid neck weakness or pain. For most patients, it is not necessary to insert the 0.5-inch needle all the way to the hub. To find the second injection site, measure approximately 1.5 centimeters, or approximately 1 finger's breadth, diagonally up at a 45-degree angle toward the superior margin of the ear from the first injection. When injecting the cervical paraspinal muscles, remember to angle the needle upward to avoid injecting any additional Botox into the lower neck region. All injection sites should be suboccipital and will typically be located within the hairline. Repeat the procedure symmetrically on the contralateral side. The trapezius is a shallow triangular-shaped superficial muscle that fans from the neck into the shoulder. A 0.5-inch needle is adequate. A longer needle is not necessary. Caution is required when injecting patients with smaller muscles. Generally, the needle does not need to be inserted all the way to the hub. Injections should be kept in the supraclavicular portion of the trapezius to avoid the inferomedial trapezius and rhomboid muscles. The fixed-dose protocol stipulates that 3 injections be administered to the right trapezius and 3 injections to the left trapezius for a total of 6 injections. The follow-the-pain optional dosing paradigm allows for a maximum of 4 additional injections given unilaterally, up to 4 on one side, or distributed bilaterally, up to 4 injections given in any combination between the right and left sides, for a total of 10 possible injections in the trapezius muscles. The inflection point is where the trapezius muscle swings from a vertical line in the cervical region to a horizontal line in the supraclavicular region. Divide the upper portion of the trapezius muscle from the inflection point of the neck to the acromion in half. The first injection should be administered at the midpoint. Stabilize the hub of the needle and inject. For the second injection, move about 3 centimeters, or approximately 2 fingers breadth, laterally from the midpoint down along the trapezius toward the shoulder. Point the needle medially and angle it 45 degrees. Inject, making sure not to go too deep. This injection, on both the left and right sides, should be approached from the supraclavicular aspect of the muscle to avoid the acromion and the deltoid muscle, as this may produce shoulder weakness. For the third injection, move about 3 centimeters, or approximately 2 fingers breadth, medially up along the trapezius from the midpoint. Stabilize the hub of the needle and make the injection. The inferomedial portions of the trapezius should be avoided to limit the possibility of neck weakness. Repeat the procedure symmetrically for the contralateral side. In the areas of maximal tenderness and/or pain, a maximum of 4 additional injections may be given unilaterally, up to 4 on one side, or distributed bilaterally, up to 4 injections given in any combination between the right and left sides, according to the follow-the-pain paradigm. A summary of the Botox injection paradigm for chronic migraine is shown in this table. The injection technique described in this video reflects the evidence-based dosing and treatment paradigm shown to be effective and well tolerated for patients with chronic migraine. This technique is specific to the formulation of Botox product manufactured by Allergan Incorporated, Irvine, California, which, as noted on the product label, is not interchangeable with other preparations of botulinum toxin products. Any questions should be directed to your local Allergan representative.